Sure what that says about me, but there you go. And the good news is it's 10 minutes to lunch and I will definitely be finished in 10 minutes. All I can say is, wow, what an amazing morning. A lot to take in, and I think really exciting from my point of view, because I love terminology, which is really sad person, I guess, but there you go. Okay, for those of you who don't know me, I'm Pam and I work in DCU, and I have been interested in terminology for probably about 15 years and working with Nick and other people in the IMEA group. I believe within healthcare reform that our biggest problem really is that we are coming probably a little bit late to the party in terms of investment in ICT around the services. I have had talks across the country with different nurse managers who say that, you know, some of their hardware, as in their computers, is really slow. Hands up who has a problem with slow computers. Well, the good news is that we're going to leapfrog over some of that, because we would be very much seen in terms of our hardware as a greenfield site, and everything is going to be cloud-based. So that's going to be solved reasonably easily, I think, in the next couple of years, now that they've decided to invest significantly in eHealth in Ireland. For me, why open this centre? Well, words in language are like the instruments that we use in a toolbox, and they can be used by the clinicians to fit their requirements. And I say clinicians because I am and have practiced for 20 years before I became an academic, and I do firmly believe that I am part of this multidisciplinary team, and for me the patient is core. So I always think of myself as a nurse and as a clinician, and I always try very much to bring the nursing piece forward as a leadership within the multidisciplinary team. That's the sort of space, I suppose, that I've always been in, and the work I've done with standards has kind of reflected that. Words create our social reality, and they influence and shape perceptions on health matters. And I think all of the speakers before me this morning have actually explained that very well, and why this is an important point. And I'm so glad that Mary and Etna and the OMNSD have decided to put this on the agenda over the next year or so to help us make some decisions around this. I'm going to talk a little bit outside the box. I hate that word, inside and outside the box, but I'm going to talk a little bit about what goes through my mind, which is probably sad, at the weekends and during the week. I'm really concerned about policy, and I'm concerned about the language of policy as a healthcare practitioner. You know, we hear all this burden of chronic disease, the tsunami of multimorbidity, the bed blockers underpinned by medical models of care delivery. And, you know, to me this sends a very strong message that chronic disease patients are responsible. They perpetuate this unhealthy lifestyle, and the systems need to monitor the risk factors described in the policy as presenting society with the challenge. Now that's a very big word before lunch, a big sentence before lunch. But in effect, what I'm saying is that nurses are very good at this, and Tracy this morning has actually identified that whole notion. And tomorrow we have a very important piece of reporting coming back with the value report from the Department of Health. So I'm constantly arguing the case here and outside of Ireland that nurses are natural leaders in this space, and we come into this multidisciplinary team group and we have a lot to say. I want to see models of care treating patients across the board with generalist, specialist and blended approaches, not necessarily just one model of care, and I think the technology is capable of doing that going forward. So we need to search for a balance between and across these proposed models of care, treating patients using generalist, specialist or age-specific approaches. And really sort of, as I said to somebody last week in the National Standards Group, we need to go down the bunny hole. We need to look at this in a serious way. How does self-care management, self-care ideals sit with, and how do we create the language in these models of care to minimise the negative impact within families? We know, okay, that technology can change practice delivery for better or worse. We have plenty of examples of that. And I do believe that partnership is core with integrity. So I work very hard with working with people at grassroots level. Where's Anne MacDonald down there? Anne does great work in public health nursing. Anne and I are working together for 10 years, and Anne has worked very, very hard and knows instinctively what it is that is needed possibly in the public health nurse domain. Or Dara Roger, an advanced nurse practitioner, or Fiona in St Mary's Hospital. These are all people who work really hard to know clinically what we need to have on the ground. Meaningful engagement equates to time investment and not tokenism. So if you're going to engage with somebody, it is a career choice, and we will do this over a 10-year period. What does patient-centred look like when you're 80 years of age? Well, I've had plenty of experience of that lately, because my dad is 85 and he's been in and out of hospital for the last 3 months. And that's really it gives you time to think. And sitting there and looking at the hospital and looking at the wards and looking at the way the nurses are working, and compare my own time as a registered nurse working in Beaumont and in other places. It's just interesting to see how nursing is shaping up. So what are the structural, social and economic dimensions that need to be considered? So these are the things that this new centre that we're setting up hopefully will start to deal with. We want to add value to the proposition. It's the same. Nick alluded to that this morning. Things aren't going to change in terms of some aspects of our care, but it's not the same. We have an opportunity now to design something that from 10 or 15 years from now, people will look back and say, God, the people who were involved in that, they really did a good job. The sustainability is there. Let me give you an example. My sister-in-law died in February of cancer. She was one of the 5 people who tamoxifen didn't work for. What if we were able to look at the bioinformatics? What are we able to start to look at embedding some of our assessments, some of this stuff that we know is coming down the road, and how useful would be that in the future for people? So that's just one example that I can think of. Our user group role within the centre that we've set up is the need to co-create and co-design meaningful in-use practice-based solutions. If this isn't going to work on the shop floor or in practice, then we need to go back and rethink it again, because everybody has a lot to do in practice and we want to make sure that we don't add to the burden of management. To do this, we need to agree on a nationally validated terminology set, and that needs to be underpinned by classification. So why am I so passionate about ICMP? I'm very passionate about ICMP because I've spent a lot of time in the last 10 years working with the national standards and the European and ISO standards. And it is a related classification. Okay? That means it belongs to the World Health Organization. And that is important. When we're talking about care integration, we're talking about what patient-centred care looks like for an 80-year-old. This is important stuff. It doesn't mean that we're not going to be able to work with models between the NANDA groups, the careful nursing philosophy and that. That's possible, but we need to also make sure that we have a strong link to WHO so that we can talk to other countries and see, as Nick was showing me with those maps this morning, it's really powerful to be able to compare data across and between the different countries, including Northern Ireland, Angela. So, about ICM. I'm not going to go into this because Nick covered this briefly this morning, but as I said, it's there since 1899, so it's there a while, and there's 16 million nurses worldwide within it. And ICMP is the actual language of the ICM. Okay? And I'm just showing you here that a core principle of ICM is integration. So coming in and leading, okay, in integrated care and making sure that we have the key core concepts that we want in there going forward. This report is very important. For those of you who haven't had a chance to look at it, and forgive me if you have, but this is probably one of the most important documents to come out of Ireland, in my opinion, in the last 10 or 15 years. This sets a framework in place for Ireland in terms of where nursing is going. And whatever we do going forward will have to link with this in terms of nursing terminology. How am I doing in 10 minutes? Where is that now?
You could.
Five. Okay. So we know ICMP characteristics. Again, I could say the same about I. Okay, there's no difference. Reliable, compliant with ICIDO, quality improvement process, formal infrastructure that facilitates cross-mapping and allows multiple formats. Interestingly, I was down in Tralee IT there about a month ago. Anybody here from Tralee? Right, I was down in Tralee talking to a postgrad group of Chinese nurses who are doing an informatics course at the moment. And they were over the moon because they were able to find in ICMP their language there. So I'll show you a screenshot now in a second, but you can go in and search by language as well. So we're looking at focusing on pre-formed, pre-coordinated statements, one-to-many catalogues, and then it can be translated into 17 languages. So we put this centre together for scholarship, for advice and support. We want to look at ICIDO, and anybody who doesn't know what that is, it's just a very, very large dictionary with 440,000 terms in it. Okay? And in effect, if you want to have an electronic record anywhere in the world, most of the countries are doing this. I can tell you that we are getting a national licence. I can tell you that the communications have already started and that we hope within the next few weeks to have that licence in Ireland for a national data dictionary. We want to develop the terminology catalogues in line with the National Data Dictionary requirements. Now, the National Data Dictionary has yet to start to be developed, but this is a real opportunity for us to come into this National Data Dictionary over the period of the next year or two with what it is that nursing and midwifery want. And really, all the service and the hospital groups that are being set up, and all of the different agencies which are out there and vendors which are being implemented, ultimately at the end of the day, the National Data Dictionary will provide them with the data that they will actually need to use. So you may be already looking at systems. I saw Joan there somewhere. Where's Joan? Joan? No? Joan's at the back there. Joan's working on the maternity and child system, and they have SNOMED codes already in there. So we'll be looking at those codes going forward. Not me personally, but the HSE will be, and making sure that they fit with the National Data Dictionary requirements. And we're also building with the CCIO. Louise referred to that. There's a huge community on the CCIO on Twitter. So if you haven't been involved, certainly have a look at that and see what you think. There's about 180 people now in the Council of Clinical Information Officers. And I did a head count there on the list. I think there's about 15 nurses involved in that. Right, Louise, about that? Yeah. So, there is nurses in there, and they're giving their time on their own bat to do this and to be passionate about the work that we hope to do. So this is what it looks like. I think what's important to mention to you is that you can go in now, tomorrow or today, when you've finished work, and you can click on this view, and it will bring up different views of all of the different terms that are in there. You can see that it links with ISO 18104, which is the standard for nursing language, diagnosis and nursing actions and terminology systems. That also works with NAMDA, by the way. And you can see here that we have a focus, an axis, and a parent, and a definition. But what's really useful for practice development people who are here today, you can go on and have a look at that site, and you can have a look at the different terms and the codes and start to see if what you're using in your current templates is actually in use. Okay? So I'm not going to go into a big long spiel between NAMDA-I and ICMP, because I think that's not productive and it's not useful. I think we have to work together, and we will work together. I think why I support ICMP is on the website. You can download it. It's a very simple 2-page article as to why I prefer ICMP over NAMDA. But at the end of the day, it's all about the quality and the patient and the care that they get. I think interdisciplinary team involvement, as I said, is appropriate. We must have problem analysis, we must have problem formulation, and we must set up the co-creators and users and actors. So this is the methodology that we're hoping to put in play over the next month or two and set up the centre for people. And then we look at the methods that we can actually, start to work in, and how we can predict the knowledge needed, or at least attempt to do so. So the goals of the centre is to establish the centre and the user group as a formal centre to advance the uptake and use of ICMP in Ireland. Establish a research cluster for mapping of ICM terms. We're already talking to Louise and her HOBIC work in Connolly Hospital, and we've already started work with St Mary's Campus. And that is primarily because when we work with St Mary's Campus in Phoenix Park, we have a group of older people who have all and many comorbidities. So we should be in a situation that we can actually improve the most frail, the most elderly, and also get a good idea of what terminology we need to do that for. Promote use of ICMP equivalences and tables. Now that's the boring stuff, okay, that nobody really wants to do, but we're going to take some of that on, and we will do it. And we're already talking to eHealth Ireland about a SNOMED licence for DCU, which has been approved. Build on the established relationships with the existing ICMP accreditation centres. Nick is setting up meetings in IMEA-NI, which is on in Geneva in June, and Dara will be attending that. Dara Roger, who's an ANP for older persons, and see where the opportunities are. Disseminate information on research activity. We will put out an annual report every year. It will be up on the website, and we want to promote harmonisation of other standard-based concepts. The Medical Oncology Clinical Information System, which is in procurement at the moment, have contacted us through the Clinical Council of Information Officers, and we are going to get involved with those, okay, around the clinical documentation piece. As I said, this is an important step today. The CCIO engagement is very important, and his ENM really have been just working away, beavering away in the background. It's a grassroots group. We give our time freely. We just try and connect people up so everybody knows what's happening in the country. And our mandate, I suppose, to some extent will come from IMEA-NI. I'm the National IMEA-NI representative for the country. I'll be stepping down in November. There will be a new one, but we try and feed in and out of the international informatics agenda for nursing and midwifery. I think we've heard this already. Certainly, you can look them up. As I said, you have the thing. And the overarching objective here is to listen, try and address some problems, and improve patient health outcomes in line with eHealth Ireland. And that's it.
Thank you very much, Pamela, and my apologies about the time. We're over time slightly. We have on our programme the Galway Clinic. Michelle, she's back. Michelle actually is the practice development coordinator in the Galway Clinic. Her role is practice development coordination and education facilitator. I think maybe it's 15 minutes okay. And we can have lunch then, and maybe when we come back in the afternoon we can maybe discuss and have a facilitated discussion around the examples and the models you were actually presented with this morning. Michelle has worked in a number of areas actually. I had the privilege of training back in the day with Michelle
100 years ago
in a previous life. She has particular expertise in mental health, and her has done a lot of work on person-centred planning, and she's finishing her PhD in that area. I want to introduce Michelle, Sinead and Winnie O'Neill. Sinead is the Director of Nursing in Galway Clinic. Sinead has worked both in the public and private healthcare systems, and she left the matter, as EM2 post, to go to the Galway Clinic. Winnie is, she's a nursing background, and her title is
Senior IT Clinical Analyst.
Senior IT Clinical Analyst. And immediately we can see the difference between the public and the private. And as I said, Michelle actually worked with me in a previous life, trained with me in a previous life, and is now working in the Galway Clinic. Michelle's doing her PhD in person-centred care, and it's the philosophy they use to support the practice development department. So thanks very much for presenting.
So this is just a very quick, brief overview